Now I'd like to invite Dr. Anubhav Goyal, and he'll be talking on interpretation and artifacts in OCTA.
So thank you KSOS and thank you team to give me this opportunity. So my talk is on OCT angiography and overview. So basically what my colleague has told, OCT is basically an additional instrumentation in our armamentarium. Good for institutes use, but for private practice it might be doubtful investigation modality. So there's a basic thing which we all use now in and out in OPD is OCT. It is non-invasive two-dimensional imaging, whereas OCTA is non-invasive three-dimensional imaging. OCT don't detects motion images, it just takes 2D images and multiple B scans to show you 2D section, but OCTA detects motion detection and it gives 3D image till the very deep layers of retina and choroid also. So this is what he has already told, some part will be repeated, overlapping. So it's a non-invasive modality, employs motion contrast imaging for high resolution volumetric blood flow analysis, visualizes blood flow down to the capillary level in choroid also. The flow which is less or more than the usual flow what it detects will be difficult to visualize over it. So the flow has to be very in the limits of what the machine should recognize. It has to be a moderate flow. So with this OCTA, since it's a non-invasive thing, you can diagnose and follow up and can repeat it on all the visits. It's easy to use and to see the pathology on repeated screenings. So pathogenesis, it's basically to study tissue volumetric analysis based on very small pixels, 5 micron resolution. So it is called as voxel. Instead of pixel, it's voxel. Volumetric analysis at the pixel level. And it repeat the images with increased reflectivity, with high decorrelation signals basically, to give an image-induced angiogram, the picture which is more with very high resolution, much more than what we do in invasive angiography. So as OCT also takes multiple B scans to give volumetric analysis, and from layer to layer it gives very good resolution of each at every capillary level. It's better than angiogram. Why? Because angiogram is an invasive technology and it takes longer time. It has a lot of side effects. It doesn't separate retinal layers and choroidal layers separately. But OCTA, since it is a 3D resolution and it goes very deeper from the superficial layers, so it can show you very definite layer by layer. It can be repeated. Every follow-up you can use it to see the improvement or worsening in the retina and choroid both. And it generates images of high contrast resolution at much better than fluorescent angiography and SCG, because patient who has allergy to these dyes can be used as a very important imaging technology. Though so these are imaging differences already discussed. So it give images just like a tissue retina choroid biopsy, like OCT, with a 3D resolution. On the left upper you can see the superficial plexus, left lower you can see the deep plexus. See the capillary level has started from the major to minor capillaries. Third one is zone of photoreceptors in the right upper side, which can very precisely show the photoreceptors, and the fourth one is choriocapillary layer. So these are the basic 4 segmentations, which gives you a broad idea at what level the pathology and imaging is lying. So along with black and white scanning, if you use color imaging, you can differentiate easily the depth of the lesion also on color imaging, because green is the superficial, red will be the deeper one. So these are commonly available OCTA machines in Indian market. SSOCT, as Dr. Jyoti has told, it is very good since the wavelength of light and used in this is 1050 nanometers. So it goes to very deeper penetration, but resolution is definitely more in spectral OCTA, Heidelberg OCTA. We are using Heidelberg OCTA, so I'll be showing images of that only. So since it has a resolution of nearly 5 to 7 microns, very deeper penetration, and the slab what it takes is 10 to 10 for high resolution you have to take 10 to 10 degrees, for wider field you have to take 30 to 15 degrees of field. Since Heidelberg has an eye tracking system, the chance of overlapping and image confusion is less. You will get a very good image because of eye tracking system in Heidelberg. So you can see left side is FFA and right side is OCTA. with a wider slab and with a posterior smaller slab. On the extreme right, you can see very fine capillaries, and the middle it is diffusely seen capillaries, and on left side, extreme left side, because of early angiogram, it's difficult to see. So OCTA will definitely show you very minor details of pathology at capillary level. So only thing is, it has to be very carefully segmented, and the segmentation, once you are using the same machine, it can be automated. Since it is an automated technology, it can be repeated at the same level. If you are using different machines, yes, it's difficult to repeat the same thing at the same level, because every machine has a different wavelength of light to take. So this is an example I'm showing diabetic diabetic retinopathy. In this, you can see enlarged foveal avascular zone, which is a sign of macular ischemia. Very faintly seen on angiogram, but on an OCTA, it is very nicely seen on right side. You can see pathology at multiple capillary level. This is an example showing microaneurysms and hard exudate, which can be seen in the middle, third at the arrow level, microaneurysm at the end of these enlarged capillaries. Though it is difficult to detect, but with careful imaging you can detect it. Fourth one is showing different levels. Yellow are the superficial layer, where you can see vessels. Green is the second layer, and red one is the deepest layer. So you can have an idea at what level the lesion is lying. This is the OCT of progression, how the diabetic showing how the diabetic retinopathy is progressing. You can see the CNP, capillary non-perfusion areas are increasing, which can be very nicely delineated on the OCTA. This is the image in the left lower corner. Surface NV is seen. So NV, capillary abnormal capillary network, can be easily seen. This is a imaging technology which will read the flow signals. So whether it is pathological or physiological abnormal vessel, it will not delineate, but it will show you that. So in this, surface NV can be easily seen, but NV very raised over the surface is difficult to delineate because of the resolution and slab. Most common imaging pathology which we use OCTA in our day-to-day is wet AMD, all know. So this is an example showing a CNVM at the level of above the photoreceptor layers. This is a Medusa head pattern of CNVM. There are different pattern of CNVM you can predict. On the left side, CFAN, or right side Medusa head, and then lower network, and other thing. This is type 1 CNVM, in which you will see CNVM at the level below the RP. So this is example I'm showing. In the third image, you're seeing CNVM above the photoreceptor layers, which is very characteristic of type 2 CNVM. I'll just rush. You can follow up the CNVM over the OCTA. You can see recurrences. It can be used in REP, as you can see capillary network following between the retina and deeper layer of retina and choroid, which can be easily seen with the follow-up of capillaries in different layers of OCTA. In MACTEL, you can see telangiectatic vessels more clearly through OCTA. You can see in the second image in the middle the telangiectatic vessels in the superficial and deeper layers, and you can follow up the progression of MACTEL in different grades through the OCTA. You can see vascular occlusion, which my colleague will be covering later on. So limitation is it cannot detect leakage, pooling, staining. OCTA misses very slow flow signals or very fast flow signals. Poor repeatability is there. Artifacts are there, which can make us difficult predicting OCTA. This is a projection artifact for large floater hemorrhage or a thick vessel over the retina can cause difficulty in visualizing lower images. Projection artifact, if there is anything on the superficial layer of retina or in the deep posterior vitreous cavity, it can project an image over it, as you are seeing water level on the lens. So this is an image. You can usually vessels are seen in the superficial slab. They are in this example, you can see these vessels seen in the third slab also, which is a projection artifact. Vessel should not be seen in deeper layer or photoreceptor layers. Motion artifact, you can see the breakage in the capillary continuity in the lower image, which is because of the horizontal eye movement. So in this image, you can see with the white lines, these are the significance of motion artifact, and you can see breakage in continuity seen by the arrow in this image, which can be rectified by repeating the OCTA. Left side, this is an image of us again, same motion artifact where the image acquisition is bad and with repeatability has improved. This is vessel doubling artifact. Segmentation artifacts are common when there is collapse, mostly in MACTEL. So through a single slab, through a single level, if you divide the slab, it's difficult to differentiate which level from which level of retina it is going.
Wind up.
Yeah. So OCTA can be used in glaucoma also. You can see differences. Thank you.